Hello and welcome to the Myositis Association's Ask the Doc webinar series. My name is Rachel Bromley. I'll be your host this evening. I am TMA's Senior Manager of Education, Support, and Advocacy. Tonight we have the honor of speaking with Dr. Sonye Danoff and Dr. Robert Hallowell. Dr. Danoff is an Associate Professor of Medicine in the Division of Pulmonary and Critical Care Medicine, Co-Director of the Interstitial Lung Disease Program, and Associate Director of the Myositis Center at Johns Hopkins University School of Medicine. Her research involves clinical and translational studies of lung fibrosis and autoimmunity. Dr. Robert Hallowell is a pulmonary and critical care physician at the Massachusetts General Hospital, where he is the director of the Interstitial Lung Disease Program and the Pulmonary Ambulatory Clinic. His research focuses on factors that influence outcomes in patients with various types of ILD, particularly those associated with autoantibodies and rheumatologic disorders. And also, both doctors are members of TMA's Medical Advisory Board. Thank you both for being here.
It's a pleasure.
If you have a question for either doctor, you can put it in the Q&A box down below at the bottom of your screen. Before we start today's Q&A, Dr. Danoff and Dr. Hallowell will take a few minutes to share their work. Dr. Danoff, would you like to go first?
Sure. Thank you so much. And thank you so much for inviting us to present and to talk about interstitial lung disease, which is, I think, perhaps a slightly less recognized part of autoimmune myositis. And I'm looking forward to our answering some of the questions that you all have for us, which have been provided in advance, as well as the ones that you put into the chat box. My work at the Johns Hopkins Myositis Center in particular is incredibly exciting to me because it gives me the opportunity to spend time with experts in many areas of myositis, including neurology, rheumatology, physical medicine, and rehabilitation, bench scientists, clinicians, radiologists. And our real goal is to try to understand what are the risk factors for patients who develop myositis, and are there specific markers that might let us know that their lungs are at risk of developing this condition called interstitial lung disease. We're going to talk a little bit more about this when we get into the questions. So the term we often use for this is phenotyping. And what that means is that when we meet many patients who have individually a very rare disease, it allows us to understand how that disease plays out or manifests itself in our patients, and whether we can learn to predict from what we've learned from our patients to help patients in the future who we care for. And specifically, my interest is in two areas, the first of which is how do we predict who will develop interstitial lung disease? And can we tell on day one when a person is diagnosed whether, number one, whether they'll have interstitial lung disease, number two, how severe that interstitial lung disease might be, and number three, what is the best treatment for that interstitial lung disease? So our area of interest really focuses around what we would call biomarkers, that is, things that we can measure that help us predict what will happen to a patient, and then also translating that understanding into choosing the best treatment options for an individual in order to provide the best outcome for them. I think I'll stop there and I'll pass it on to Dr. Hallowell.
Thank you. It's a great pleasure being here, and I appreciate those who are taking time out of their busy day and home life to spend a little time with us and hopefully learn something. My work is actually rather similar to the work that Dr. Danoff is doing, in part because I trained under Dr. Danoff when I was a bit younger and was inspired by a lot of the work she was doing back in the day. And so in a similar fashion, my work is mostly clinical, focusing again on trying to understand more about myositis and other connective tissue diseases or rheumatology related diseases, how they influence the lung, why certain patients get lung disease, other patients don't, and why our current treatment strategies work for some patients better than others, and trying to figure out what the optimal treatment strategy might be. And part of the challenge with some of these conditions is that compared to other diseases that we see in this country, they're actually relatively rare. And so we don't have the large, studies of tens of thousands of patients that a cardiologist might benefit from with some of the studies they get to do. And so even though we've known about these conditions for many, many, many decades, we actually have a pretty poor understanding of even what they entail and how patients present. And so my work focuses on trying to define the process, how patients progress, and similar to Dr. Danoff, looking at certain markers in the blood, in lung samples. And I also try to serve as a bridge between the clinic, where I'm pretty active seeing patients several days a week, and the bench, where we have a lot of basic scientists here who are looking at molecular structures and chemical pathways in the body, and helping to sort of bridge that gap, bringing patients from the clinic and their samples to the bench, what we call translational research, to try to bridge that gap. And some of those kind of studies are what industry and pharmaceutical companies use to then spin off new therapeutic drugs in the future. And so that's sort of the big picture of my research aspirations and what we hope to achieve with the work that we do when we're not seeing patients.
Thanks, Rob. That was a great introduction. I wonder if, Rachel, would it be okay for us to start answering some questions?
Sure, go right ahead.
All right. So I'm going to start off by sending a question in Rob's direction. And I'm going to ask you, if you don't mind, to start off by talking a little bit about what interstitial lung disease is, and then how is it, what are the tests that are done to make a diagnosis of interstitial lung disease, and maybe even talk about some of the symptoms that are suggestive of interstitial lung disease.
Yeah, sure. I'm happy to start with that. So I think before we talk about anything, any concept, any ailment, it's really important to be able to picture or conceptualize what we're talking about. And so I think this is a really good place to start. And when we're talking about interstitial lung disease, what does that really even mean? And when we think about the lungs and we think about the way the lungs can get sick, I find it useful to think about different compartments or parts of the lung. When we breathe air in, the air comes into our big windpipe, the trachea, and then that air moves into our lungs, into smaller and smaller branches of airways, our bronchioles, bronchi, and then it goes all the way down into these tiny, 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 tiny air sacs. And most of us are familiar with different lung ailments or diseases that affect the more common parts of the lung. When the bronchi get inflamed or infected, we start coughing and bringing up mucus. We call that bronchitis, right? And I think a lot of us have experienced that. And if that infection gets deeper down and it fills all those tiny little air sacs that we use to absorb oxygen, that infection is called a pneumonia. And as you can imagine, that's a much more severe disease, because now each of those tiny microscopic air sacs or balloons are actually filled with fluid or with infection or pus, and it affects our ability to absorb oxygen and breathe. That's why you need more antibiotics. You can be really sick in the hospital, et cetera. But interstitial lung disease is completely different from any of those things. And so if you imagine all these tiny little balloons, the interstitium, or what we call the interstitium of the lung, is actually the lining of each of those little balloons. And so each little balloon has a lining around it that makes the balloon itself. It's the rubber that makes the balloon. So it's not the inside of the balloon or the airway that leads to it. It's what makes the outside of the balloon itself. And each of those little balloons is supposed to be made of very, very thin rubber that's pliable and easy to stretch every time we breathe in and breathe out. And if you've ever tried to blow up a balloon, if you try to blow up a balloon that's really stiff or that you haven't stretched at a birthday party, you have to really work. Or if you try to blow up a whoopee cushion that's not supposed to blow up well, it's not easy to do that. And so with interstitial lung disease, that thin, really compliant rubber starts getting thicker. And so each of those little balloons, they're thicker, they're harder to expand. And so every breath you take, it's more work than you would expect it to be. And your body interprets that work as shortness of breath. Because that rubber is thicker as well, all that oxygen you're breathing into your lungs, that oxygen that needs to be absorbed across that rubber into your bloodstream, which is the purpose of each little balloon, to be a little membrane across which oxygen is absorbed, it's harder for the oxygen to be absorbed because the rubber is thicker. So it has to travel further to get across the rubber. And sometimes it doesn't get across the rubber at all to get into your bloodstream. And so it can affect your oxygen levels or require you to be wearing oxygen to compensate for that fact. And so in a nutshell, that's sort of what interstitial lung disease is. And the challenge for physicians like Dr. Danoff and myself oftentimes is figuring out, okay, well, each of these little balloons is thicker and it's abnormal now when you see it on the CAT scan or on a biopsy, but what's making it thicker? What is the actual problem with the balloon? Is it thicker because there's scar tissue there, what we call pulmonary fibrosis? Is it thicker because there is inflammation or what we call an immune response, so the body's own immune system sending in white blood cells, which also can make it thicker, inflamed, kind of the way your skin gets swollen or red when you cut it? That's inflammation. Or is it a combination of those two things? And so there can be an overlap between those. And so trying to figure out which of these processes are at play will often guide how we approach the situation. And so that having that framework and that understanding of what is interstitial lung disease, and then is it more inflammation? Is it more scar tissue? How do we treat those two things? And if it's something in the middle, how do we approach that? And that's kind of what I think about with every patient I meet, and I find that framework helpful. So with that, the symptoms that come with interstitial lung disease, I alluded to a little bit. They're, trying to stretch those thicker, stiffer little balloons. You've got tens and tens of thousands of them. That creates this sensation of working harder to breathe. So patients feel more out of breath, they feel winded, and they may notice that that walk they used to take up a hill in their neighborhood, they can't do it as quickly as they did before. Because sometimes people slow down subconsciously. So they may not feel out of breath at first, but it takes them a little bit longer, or they can't keep up with their relatives when they're walking. They feel out of breath when they get to the top. So you start noticing your breathing a bit. Some of our patients, they start developing a cough. The cough is oftentimes not productive of any mucus or sputum. Sometimes it is, not from infection, but just from inflammation. But very often it's a dry cough. And this can mimic other things like asthma or infections. And so it can be misleading at first. And sometimes we have patients who have a really hard time putting a finger on it, but they just feel tired with activity. And it can be hard for them to pinpoint a sensation of breathlessness. They just feel tired when they try to exert themselves. And that's sort of their body equivalent of working harder to breathe. And so these are some of the things that we listen for, or that your rheumatologist or primary care physician will listen for when they're taking a history to think, is there a red flag here? Is there something that may indicate something going on with the lungs? And so then the question about workup and the testing, which I think was the stem of the question here and what prompted this. So the physical exam is one thing. So your doctor will listen to your lungs and listen to see if your lungs sound clear, or do they hear extra sounds with their stethoscope that may imply that there's either some inflammation or some scar tissue there. So sometimes we can hear things that make us suspect something might be going on. And then there are breathing tests that we do. So what we call pulmonary function tests, where we have you bite onto a tube, it's like a snorkel, pinch your nose, and have you blow into a machine. This measures your lung function, and those numbers that we get, if those numbers are not normal, can be a hint that there might be something going on with the lungs. But But all that said, I would say that if there's a suspicion that something is going on with the lungs because the breathing doesn't feel normal, the most definitive test and study to really show whether or not there is an interstitial lung disease is a CAT scan of the chest. And so getting a CAT scan to look at the lungs definitively is, in the end, in my experience, the only way to know for certain whether or not interstitial lung disease, at least in the early stages, is present.
So that was a great review, Rob, and a great place to start. And so it sounds to me like what you're saying is that the kinds of symptoms that would bring somebody who has myositis to be seen by a pulmonary doctor, lung doctor, might be that they're short of breath, particularly when they're exerting themselves, walking up a hill, walking up a flight of stairs, more short of breath than they used to be, that they might have a cough, and it may not bring up a lot of phlegm. They may just feel fatigued or not like themselves. And then the testing that they might get after their doctors listen to their lungs might include these breathing tests and the CT scan. And so I think that's a great place to start in terms of thinking about how, what are the kind of things that would make you want to talk to your doctor about, gee, I'm worried about this, or I think that there might be something wrong. Do I need to get more testing done? Do I need to go see a specialist? I think that's a great place to start.
Yeah. Thanks. All right, well, we have another question here. All right, Dr. Danoff. You look warmed up, so this is not an easy one. Are you ready?
It's a slow one to me, please.
Well, this is a challenge, and I think we can all kind of relate to this and empathize. I cough sometimes even to the point of vomiting, and it just wears me out. What do you recommend for a chronic dry cough? Rituximab, prescription medications, and over-the-counter syrups aren't helping. And I think this is, I kind of alluded to this just before, and unfortunately, this is a common complaint and can be quite debilitating. So I'm curious to hear if you have any magic.
No, I mean, I think that what this really points out is that, everybody experiences their autoimmune myositis in different ways, and they experience their interstitial lung disease in different ways. And so for some people, cough is really the most troubling symptom. It's not even so much that they feel short of breath. It's just that the cough is really disabling because it makes it very clear that there's something wrong. Everybody's very concerned, especially now in the COVID era. Coughing is obviously draws a lot of attention to people. And it can be really hard to control. There are a couple of different reasons that people develop cough. And one of the things that we do when we talk to our patients is try to focus in on what is actually causing the cough, or when does the cough occur. So sometimes people get cough that is worse at night after they lie down. It might wake them up from sleep. And that kind of cough we often associate with people having gastroesophageal reflux, which is where some of the acid or stomach contents swish back up into their chest, and that triggers the cough reflex. And for those patients, we would treat their reflux disease. We would have them do things that diminish their reflux, avoid foods that cause reflux, elevate the head of their bed so that their head's up a little bit when they're sleeping at night. They may be doing that already because they know that that makes them cough less. There's some people who cough because they have that they cough when they eat, and that's because they have difficulty with swallowing. Myositis can affect the swallowing muscles, and some people notice if they drink something or eat something too quickly, they start to cough. And that might tell us that we need to evaluate how their swallowing function is. And some people cough because they've gotten an infection, because many of the medicines we use for treating myositis are ones that lower the immune response. And so it's easy to get an infection. We've just lived through 2 years of an infection that's affected millions of people. And so we want to be sure that there's not an infection that's causing it. And many people know that they've had it for months and months and months. That makes it less likely. But we do want to make sure it's not an infection. And then the last part, which I think is probably what this question was really intended to ask about, is what if I have interstitial lung disease and the thing that it does is it makes me cough? And that cough can be really, really hard to manage, because essentially what's happening is that the irritant receptors in the lungs, the things that were put there so that, thousands of years ago when we were out on the plane, if there was a dust storm and little dust particles got into your chest, you would cough to get rid of them. Those irritant receptors are turned on, like the volume is turned up. So even the littlest thing, I walk from outside into my air-conditioned house, it makes me cough. Somebody walks past me with perfume, it makes me cough. And it's just that these irritant receptors have gotten really super active. And usually what we do is a variety of things. If we know that there are specific things that trigger people, we'll try to avoid them. So if drinking cold liquids triggers you, we may say, try to drink, room temperature, lukewarm water rather than drinking cold water. Or we might say, avoid situations. If going out in the cold is going to make you cough, put a scarf around your mouth, or now put a mask over your mouth so that you don't have that cold air coming in. And then we also will use local things like cough drops, because actually just having the back of your throat be moist can often control the cough. And then we kind of escalate from there. Some people take over-the-counter medicines, and sometimes when it's very serious, we use other medicines that contain medications like narcotics or codeine, and that can also be a cough suppressant. That's a very effective cough suppressant. But we try to start off with the thing that is the least intrusive and then kind of escalate up until we've got the level of control that's needed. Now, one of the things that's really exciting and from a research standpoint is that there are currently a number of drugs that are actually directed at controlling cough, which are being tested for people who have interstitial lung disease. So it may well be that in a couple of years, we'll have much more directed therapy for treating that cough. But it is a tough symptom to deal with, and it's often the most disruptive for our patients.
Thank you.
Well, I'm going to transition to another symptom that's very tough and ask you, Dr. Hallowell. A patient said, I'm finding that it's harder to climb hills. I get very winded. I've not been diagnosed with interstitial lung disease, but I wonder what is causing the rapid decline in my heart and lung function. Is it time to consult a pulmonologist? I think that's a great question.
Yes. Well, let's talk a little bit about that. I think that's a good segue. And then I think, there are some questions in the chat about symptoms and muscle weakness, et cetera. So I think this is a timely question. So I think, we're lung doctors by trade. And so we see patients with lung disease, but not everything that comes into our clinic, not every breathing symptom is due to the lungs. And I think it's important to sort of keep an open mind, what we call a broad differential, and try to think outside the box a little bit about the various things that can affect patients. And so other than truly having lung disease or interstitial lung disease associated with various forms of myositis, there are many other things that I think we need to keep in mind here. One is that simply having a chronic inflammatory condition or a chronic autoimmune condition over time can take a toll on the body and cause chronic fatigue, muscle breakdown, and weakness. And it's very easy to become deconditioned. The pandemic certainly has not helped this. And I think the overall activity level of patients drops even without them realizing it when they don't feel well. And if we were to put an activity tracker on people, not just measuring steps walked per day, but the intensity of those steps and the speed with which people are walking when they don't feel well, either because of back pain or this ache or something else bothering them, everything slows down. Even just having a cold, when your nose is congested, you slow down. And so when you feel not well because you're fatigued or you have malaise or you just don't feel right, even if it's a bowel issue, you just don't feel right chronically for weeks to months, your activity level has declined and you get out of shape. And your heart is a muscle, and if it doesn't get exercise, it also gets out of shape. And so, the less you're pushing yourself and exercising, the more you're going to notice it and feel winded when you do try to push yourself and exercise. And this becomes a slippery slope. So deconditioning is certainly a large part of some of the breathing symptoms that we see in all of our patients, irrespective of what their pulmonary function is on testing or how stable their CAT scans are. And so it's important to try to stay active as much as possible, even though it's often the last thing you want to do when you don't feel well. So that's one thing to keep in mind. In myositis patients specifically, within our autoimmune groups, muscle weakness is something that needs to be taken into consideration. And keep in mind that you use your muscles to breathe. And so there are muscles of respiration that we call them. And if myositis decides that it wants to target the diaphragm or other breathing muscles, it can actually be harder to breathe because those breathing muscles are weaker. And your brain and your body will interpret that weakness with every breath you take as shortness of breath. Even if you have no interstitial lung disease on a CAT scan and everything is perfectly fine in your lungs, you will feel more winded trying to breathe that way. And there are different types of pulmonary function tests or breathing tests that we can try to do to tease that out. Because sometimes breathing tests start looking abnormal and it's from muscle weakness, not lung disease. And so there are different additional breathing tests that we can do to try to eke out and tease out whether or not that's from muscle weakness. Patients sometimes can have elevated pressures in the heart and pressures in the lungs. So elevated blood pressure in the lungs, something called pulmonary hypertension, is something that we think about sometimes. So inflammation that affects blood vessels that run through the lungs, can cause those blood vessels to be less compliant or constricted. And so the blood flowing through the lungs goes through at a higher pressure. And so that can also cause shortness of breath. And then there are certain cases, it's not common, but I have had patients where the medications they take for their condition make them feel weaker or more fatigued or just generally not well. And we have to be mindful that a lot of the medications we prescribe can be a double-edged sword. And that, patients don't always feel better because of the medications we give them. Sometimes they feel worse, and we have to think about whether medications are amplifying a symptom or causing a symptom. And so I think that's a very long-winded way, no pun intended, of saying yes. I mean, I think if you are having worsening breathing symptoms, whether your rheumatologist or primary care physician can explain them or not, whether you have interstitial lung disease or not, if you have an underlying autoimmune disease or a rheumatologic condition, I think it's worthwhile seeing a friendly pulmonologist to walk through these symptoms and kind of go through this thought process with you, because that's our job, is to try to tease these symptoms out and sometimes say, well, maybe it's not the lungs, but we don't mind seeing those patients in clinic. That's part of our job. And so don't be shy if you're having symptoms like that.
Right. And I think one of the things that sometimes we forget, because the name of the disease is myositis or dermatomyositis, it suggests that it's just muscles or skin and muscles. But the lung is also, as we're talking about today, is also a target for a variety of reasons. And so I think sometimes it can be easy if your doctor's not really thinking about it, or if maybe that's not a focus, to miss that that's something that could be related to the disease. Certainly not rheumatologists or neurologists who have a lot of familiarity with it, but maybe somebody who has less familiarity. And so I think it's really important to advocate for yourself as a patient. And if you develop a symptom that is concerning to you, bring it up with your doctor, ask them what their thoughts about how it could be related to your other diseases, your autoimmune disease. And then see what further evaluation needs to happen. I think, unfortunately, we sometimes see patients where the diagnosis is made late because it's just sort of missed. And generally, that's not the people who have the classic muscle weakness and skin involvement, but the people who develop their interstitial lung disease first, who get short of breath first. And then it takes a while for that to be recognized as being part of their dermatomyositis or polymyositis. So definitely advocate for yourself. If there are symptoms you're concerned about, bring it up with your doctor and just try to come to an understanding about how it might be related and what else needs to be done.
Yeah. No, I think that's a great point. As a segue to that, and this ties into actually some questions coming through the chat, the live chat as well, in terms of symptoms and deconditioning and these things that play a role. Are there exercises that one can do to strengthen these muscles? So breathing exercises or other focused exercises. And so what are some of the best exercises for people with myositis, whether they have underlying ILD or not? Any recommendations for that?
Sure. So I want to just be very clear. I am a lung doctor. I'm not a rheumatologist or a neurologist. So I'm not going to make comments specifically about muscle exercises, but I do want to talk about the concept of pulmonary rehab. And I think that Dr. Hallowell really pointed out that it's very easy for anybody who's ill to become deconditioned, that is, for their muscles to become weaker than they used to be. And I think it's especially true when the disease we're talking about affects muscles as one of its primary manifestations. And so when we see patients who have been ill, maybe they've been in the hospital, maybe they're just coming in to see us, but they can't do as much as they had done before, we recommend exercise as being one of the main things that they do to try to get better. It's something that can often be done in the context of a rehab program for our patients with interstitial lung disease. We send them to pulmonary rehab. You may know people who've gone to cardiac rehab after they've had a heart procedure done. But basically, these are monitored exercise programs that can help you increase the amount of activity you do while monitoring you to make sure that things are safe. During the pandemic, a lot of our rehab sites closed down because of the concerns of people transmitting COVID to each other in the programs. And so there are now some really nice online pulmonary rehab programs. And I'll just put in a plug for one that is available through another patient advocacy organization called the Pulmonary Fibrosis Foundation. You can look it up under the Pulmonary Fibrosis Foundation Pulmonary Rehab Toolkit. And it has 8 sessions of online pulmonary rehab. They're available free to anybody who wants to do them. And I think that really what we're talking about is exercises that both exercise the legs, which are big muscles that are often used for aerobic exercise, but also upper extremities, arms, because those muscles of the chest and the back are muscles that we use when we breathe that maybe don't get as much attention when we're doing kind of walking as our primary activity. But really, any kind of routine exercise is better than nothing at all. And you should really talk with your doctor to try to tailor it to what are your needs and your other health limitations. Maybe there's some things that you should do and shouldn't do. And so have that conversation with your doctor about which exercises might be best for you. But for patients with interstitial lung disease, we would definitely think about referring them to a pulmonary rehab. And if that's not available, then again, you can get online resources for pulmonary rehab. So I know we were going to move over to talk about some COVID issues, but I want to just throw one more question to you, Dr. Hallowell, from the chat. And this has come up, and I know this is your area of interest and expertise, is really about how autoantibodies can tell us about whether people might or might not get interstitial lung disease. And the antibodies that have come up a lot in the chat have been about MDA5. and then a group of antibodies called the anti-synthetase antibodies. Do you mind talking about that a little bit?
Yeah, no, happy to. So one thing that we've learned over the past few decades now is that not all patients with myositis get interstitial lung disease. And as you mentioned earlier, Sonia, some of your research is looking at why some patients do, which patients do or don't, what some of the risk factors are for interstitial lung disease development. There are certain antibodies, autoantibodies in the blood, which are markers of autoimmunity, or sort of signs in the blood that the immune system is confused and trying to attack different parts of the patient's body. Some of these antibodies, what we call the anti-synthetase antibodies and MDA5, are what are called myositis-specific antibodies. So these are antibodies that are traditionally found in patients who have myositis. Now, that being said, there are patients who have these antibodies and they actually don't have much in the way of muscle disease, or their muscle disease is actually quite mild. So the name is actually maybe a bit of a misnomer. And they can actually have primarily just lung involvement. So for whatever reasons we don't understand, the immune system being confused, trying to attack, the patient's own body, is pretty much ignoring the muscles and saying, nah, I'm just going to bother your lungs, or ignore your joints. I'm not going to cause joint pains in you. I'm not going to cause a rash necessarily even. I'm just going to focus on your lungs. But in other patients, it affects their skin, affects their joints, affects their lungs, and affects their muscles. So we don't have a good understanding yet why some patients have just one part of their body affected or several parts of their body affected. And some of the research that I'm doing, certainly the research that Dr. Danoff has been doing, is trying to tease this out. And one thing we've noticed is that some of these antibodies in the blood perhaps loosely correlate to some of these patterns we see. And some of the patterns that are emerging are that antibodies such as MDA5, for instance, are more likely to be associated with certain types of rashes or certain types of ulcers on the skin. Not all the time, but more often than not. Other anti-synthetase antibodies, some of them, depending on which one you have, may increase your risk of having Raynaud's phenomenon or cold fingers or joint swelling or muscle involvement. As a whole, all of these special antibodies tend to increase the risk of having interstitial lung disease. So patients who have these antibodies are more likely to have lung involvement than patients with myositis who don't have the antibodies. Having the antibody doesn't mean you're guaranteed to have interstitial lung disease, but the chances are much higher. There are questions in the chat about the levels of these antibodies, whether you're tighter or how high the MDA5 level is. Does that matter? This is actually a topic of very intense debate. This has been studied pretty extensively by many respected groups out of Japan, and they've looked at this. And it's a mixed bag, but the level may correspond to how active the disease is. And so a higher level may give a greater risk of interstitial lung disease or more active disease, but we're not sure. So, one of the things we look at when we try to determine, is a patient at risk for having interstitial lung disease, or are they at risk for the lung disease developing more rapidly or progressing more rapidly, or which antibodies do they have or not have, and do those antibodies place them at greater risk of the disease coming back if we taper their therapy too quickly, et cetera. And so, because these are relatively rare, it's hard for us to get 500 patients with anti-KU antibody, because I know there are patients in the chat who have that, or even 500 patients with an MDA5 antibody. It's hard to get sort of a critical mass of patients with each of the antibodies to get a really good understanding, but we're getting closer. And so it's a long-winded answer, but
And I think, I think the one thing, so firstly, I mean, I think the take home message is antibodies can tell us a little bit about what is more or less likely to happen, but every person is unique. And autoimmune myositis is really like the epitome of the place where you see that everybody is different. And so having the two people with the same antibody can have very, very different disease. And I think that the other thing that I just like to mention is that this is why it's so valuable if you feel comfortable with participating in research, why that's so helpful, because many people, even not participating in what we call a clinical trial is where a group of people is going to try a specific medication and maybe another group of people will try something that's called a placebo. That's one type of trial. But what we're doing at many of our myositis centers is what are called observational trials, which just means we want to understand what your disease means to you. We want to just be able to learn from the experience that you're having. We might ask you about your symptoms. We might test for specific markers in your blood or look at your CT scans. All of that knowledge is really critical for us to be able to answer many of the questions that you all are asking us today. So the more people are comfortable with participating with research, the more we're able to really provide better care for our patients. So I know that the TMA is very, very actively involved in supporting research. And I think that that's such an important thing if we want to have the kinds of answers to the kinds of questions you're asking today. We have to do the research today to have those answers for you tomorrow. Some of the questions you're asking, we know the answers because we've done the research already, but that really is what it's all about.
Great.
All right, should we transition and talk a little bit about COVID since that's on a few people's minds?
I think so. There have been quite a few questions, broad strokes COVID related. I think we should at least answer one or two of those, because I do think it is relevant to this group as a whole. So let's see. Dr. Danoff, some ILD patients are nervous to go for the routine PFTs, echocardiograms, and chest CAT scans due to possible exposure to COVID. What is your advice for these patients who have not been tested since 2019, but are feeling pretty stable? And I'm also going to add on to that and say, well, what if I'm not feeling pretty stable as well? So I think there's a whole spectrum here that you can maybe bake into your answer, make it applicable.
Sure. Well, I'm looking forward to your input on this as well, Dr. Hallowell. But basically, the last 2 years have changed everything for, I think, all of us. Certainly we've lost close to 1 million people in the United States, which is just horrifying. But I think that for our patients who have interstitial lung disease or autoimmune myositis, this has really created a potential barrier to getting care. Some patients, as this question implied, are fairly stable, and that's wonderful. Many people are not and need to have that interaction with their healthcare provider. Now, obviously, we've gone from like 0 to 60 or more in terms of using telemedicine for seeing our patients, even when they can't come in to see us in person. And I think that that's very, very helpful and has been really a savior in the last couple of years. But there are also some tests that we use to try to understand how people are doing. And those are things like the pulmonary function tests, which are the breathing tests, or CT scans, or else pictures of the heart called echocardiograms. And I think that when you're, if you have disease where you're being treated and you've potentially tried a new therapy, or you've been placed on a new therapy, or your symptoms are getting worse, your doctor might say to you, I think that it is so important for you to have this information, for us to know if this medicine is working for you, or if this approach is working, that I think it is worth the risk for you to come into the clinic. And in the clinics, I think that, the things to remember is that people are very, very aware of the risk of COVID. The vast majority of healthcare providers, healthcare staff are vaccinated. You're going to see people wearing masks in the healthcare environment. And for sure, if you have an autoimmune disease and you're on an immunosuppressant, please wear your mask when you come into the healthcare establishments. And so I think it really involves a discussion with your healthcare provider about how are you doing and what are the likelihood that the information that we would get from a test would change what we would do. Would it mean that we would be able to maybe take you off of a medicine? Would it mean maybe that you needed to have another medicine added if it wasn't if the tests were worse and the medicine wasn't working well? So I do think that there is a role for testing, and I think that this is very individualized, and that a lot of this involves communication with your doctor. The other thing that's really different now is that at the beginning, we really had very little to protect our patients from developing COVID-19. Now we have many, many tools to protect against COVID-19. When we started off, we just asked people to stay apart, put a mask on. Then vaccines became available. That gave us another layer of protection. Now we have monoclonal antibodies that can be used if you're either exposed to somebody with COVID or if you develop COVID. And there are also pills now that can be used to treat COVID. So I think we're really in a very different place than we were 2 years ago, where we legitimately were not sure if it was safe for our patients to come in. Now, I think if you and your doctor have the conversation, they say, I really think that this test is important to know whether we're doing the right thing. I would have a much higher level of confidence that it would be safe to go in and do it. But definitely, if you have any questions or concerns, talk to your healthcare provider and express that concern and see how they feel that it fits for you as an individual with your individual disease and with the individual situation in your community.
Yeah, I think that's a really good answer. And I think we've all struggled with this for a few years now. And your point about, this has obviously turned healthcare upside down. It's turned everybody's lives upside down. And I think the point about individualizing the response, though, is critical here. And, when you're dealing with certainly a process like interstitial lung disease, at some point, it is going to be important to have a check-in and to make sure there isn't some kind of ongoing progression of the process that would need to be intervened on. And finding exactly when that perfect timing is relative to what type of disease you have and where you were in your trajectory before COVID started, is the conversation you'll have with your physician. So I think that's a good point.
They're tough questions. They're things that we've really been wrestling with, and I know our patients have been wrestling with them as well. So, Dr. Hallowell, one of the things that people are really thinking about is what lies ahead of us. So, will it be safer for people with myositis and ILD to go out in public once there are more therapies available for people who've been exposed? There's a question about, do you have like a time course? Do you have like a date where like life might go back more towards normal? How are you counseling your patients on this?
Yeah, tough question. Partly a good question for Dr. Fauci, but I tried texting him earlier today and he was unavailable apparently. But the short answer, which you alluded to with some of the therapies, is yes. We're already doing much better treating COVID when patients get sick with it, right? So we already know that our outcomes are markedly improved from when this all started. So we have made strides. We've learned about the disease process, how it spread, et cetera. Our infection control in the hospitals, in the clinics, in the breathing test labs has improved markedly. So, I think just in terms of preventing people from getting COVID, treating people when they get COVID, we are doing better. And I think, having hopefully the growing option of using medications like remdesivir as an outpatient when it becomes more available will help to reduce hospitalizations if that data holds up. Having the new oral medication, Paxlovid, which is an antiviral pill that has been shown to hopefully, if the data holds up, to be effective at reducing need for hospitalization and bad outcomes in patients who can take this before they get so sick they need to be in the hospital. And now the biggest breakthrough lately, especially important for a lot of the patients on this call, because I'm looking through the chat and other questions we had received ahead of time, and I'm seeing rituximab, and other immunosuppressing agents, and stories about I'm getting vaccines, I'm not getting a vaccine response, and my antibody levels are low, but do I still have T cell response? I don't know. I mean, so these are kind of the things that I'm seeing coming through in the chat. And so now with Evusheld, right? So Evusheld is this new long-acting monoclonal antibody that seems to offer protection against COVID in patients who are immunocompromised, who either can't get a vaccine or where the vaccine is not effective. And this seems to be, a ray of hope for our most vulnerable patient population. And so, it was hard to get, and even at our own institution here, supplies are becoming more readily available that we can start rolling this out. And so I'm hopeful that in the next several months, we should be able to get more patients on this monoclonal antibody preventive therapy. Case infectivity rates following the Omicron wave are again coming down. I mean, at least here in Massachusetts, we went from like 33% positivity rate to, I think now we're down to like 3% or below 3%. And so, things are moving again in the right direction. The weather's going to get warmer, right? So I'm hoping this is a confluence of good news. I don't think COVID is going to be gone completely in 6 months. I think we all know that is probably not the case. But I think people will be able to relax a little bit. It's not going to be perfect. It's not going to be normalcy, but at least allow some step towards normal activity without petrifying fear of COVID behind every corner. It's my hope. But I'm an optimist, so I've been told.
Doctors, we have about 7 minutes until close of show.
So there's been a lot of questions, Dr. Danoff. Quite a few questions, actually, with a common theme that I'm going to stitch together and package for you with a little bow here. Broad strokes, do treatments for ILD related to myositis, are there treatments that work? Can you treat patients? Do you treat patients successfully? Can this be stopped? Is there hope therapeutically?
Absolutely. And I think that, one of the reasons that Dr. Hallowell and I both love this field is because it's a place where, although I don't want to minimize, there are many, many patients who have very severe lung disease that we're not able to make better. There are also many patients who we do get better. And, there are really excellent therapies that are available. The real key is early recognition and treatment follow-up, and just sort of having all the little details followed carefully. It's one of the reasons why it's helpful to, to see somebody, if you're able to, who has experience in interstitial lung disease and, ideally experience in myositis and interstitial lung disease, because that way, some of those details can be followed carefully, and there are many current therapies, but there are also lots and lots of new clinical trials that are coming out. And I would commend to you clinicaltrials.gov, which is the National Registry of all clinical trials. You can put in myositis and ILD. You can see all of the trials that are available in the United States and actually also abroad. And so, yes, recognition of ILD is very important. treatment can be very successful. It's often not a single straight line. It's often a very bumpy road that our patients go down. But I think that, we have had some, overall very, very good success. But we do know that it's that early recognition that makes all the difference. And then, being persistent. If one therapy doesn't work, then we need to think about another therapy. And that sometimes can be very frustrating to our patients. But as long as we persist, I think we generally have very good outcomes. So we have just a few minutes left. Any final words for us, Dr. Hallowell?
First of all, I think I can't see anybody who's out there, but you're all beautiful people. And I think your strength, your courage throughout all of this, right? To go through a pandemic with a disease that tries to bring you down every day and make you feel terrible every day. People who have lung disease, who feel that their breathing is not normal every day. I mean, I whine when I get a cold. My wife thinks I'm a baby, but you're the real heroes in this, and your strength, your fortitude is so inspiring, and it's why Dr. Danoff and I do what we do, and give us a passion and a purpose. And I'm always amazed by the grace and strength of all the patients I meet. And I will also tell you that there are cases that we can't fix, and there are patients we can't treat, and there are horrible days where the news we deliver and the outcomes we have are not good. But I have a whole clinic filled with patients I've known for almost a decade that were told they have 1 to 2 years to live. And I think it's important to know that you are not some statistic on the internet. You are individual. And I have never done a physical exam and looked at somebody's skin and seen an expiration date stamped on them like they're a carton of milk. And so I think as long as you are going and as long as you are trying, I think there is hope. And as long as there are people willing to fight for the cause and willing to help with our research, we have hope of conquering this disease and fighting it back, whether we're talking about the muscle disease, the lung disease, or a combination thereof. So keep fighting. We'll keep fighting for you.
I think that was the perfect way to end this. Thank you very much, Dr. Hallowell. That was the bottom line.
It was. Thank you both so much for participating in today's webinar. Thank you so much for your inspiring words of hope. It really is a nice note to leave on today. We appreciate the work that you do. So, all right. Thank you all for participating tonight, and be sure to tune in next month, March 17th from 6 p.m. to 7 p.m. Eastern Time, where we talk with neurologist Dr. Tahseen Mozaffar. Thank you. For TMA, I'm Rachel Bromley. Good night.